my dear friends. I welcome you all to the today's daily dose. I am myself Dr. Rajesh Gubba. I am a cardiologist and I am also the mentor for teaching general medicine in exams like NEET PG, AIMS, PGI and as well as JIPMA. So as the part of today's daily dose, I have a 41-year-old woman. She is referred for assessment after suffering a second pulmonary embolism within a year. She has not been traveling recently, had not any surgery, does not smoke and does not take the oral contraceptive pills. She is not currently on any medication as the diagnosis is retrospective and she is now asymptomatic. What would be the next step in her management? Options: initiation of warfarin therapy, ECG, thrombophilia screen, insertion of IVC filter, duplex scan of lower limb veins and pelvic ultrasound. See, in this question, the point is that the individual is having recurrent pulmonary embolism, that is second pulmonary embolism. But the point is, there are no acquired risk factors for the development of pulmonary embolism. Like what are those? No travel history, no history of any surgery, right? Because after surgery the individual will be usually bedridden and there is chance of the deep vein thrombosis. That history is not there. And there is no history of smoking because smoking itself is a hypercoagulable state where the individual can develop deep vein thrombosis or thrombus in the pelvic veins. And the individual is not on any oral contraceptive pills because the oral contraceptive pills which are rich on estrogen, they are very prone for the development of thrombus that may have even the DVT or pelvic vein thrombosis resulting in pulmonary embolism. So there is no acquired risk factors according to the history for the development of the pulmonary embolism. But the individual is having recurrent pulmonary embolism, right? And she is not currently on any medication. That means even during the first attack of your pulmonary embolism also, she had the management at that particular point of time and after that she is not continuing any medication. But again now she had a second pulmonary embolism. Now what is the line of management to her? See, in this clinical scenario, we need to work up on what is the cause of the underlying pulmonary embolism. See, when there is no risk factor for the development of the acquired risk factor for the development of pulmonary embolism, what you need to think? You need to think some genetic disorder or inherited disorder for the development of thrombus formation resulting in the development of pulmonary embolism. So now you take the options: initiation of the warfarin therapy, ECG, thrombophilia screen, insertion of IVC filter, duplex scan of the lower limbs and pelvic ultrasound. So what do you think is the appropriate answer in this particular question is the thrombophilia screen. First, I will tell you why and then we will rule out the other options. So if you take this thrombophilia screen, why I want to do it is, I want to do the testing of the hypercoagulable disorder because the individual is having recurrent pulmonary embolism without having any acquired risk factors. So the thrombophilia screen is the best answer in this particular question. Now, for suppose I initiate the warfarin therapy, what is the use? Right? So once the patient stops the warfarin, again there is a very high chance that there is a formation of the pulmonary embolism. So I don't know like what is the exact underlying cause for the development of pulmonary embolism. I cannot do just a symptomatic management in this patient. Next, so that is the reason why your first option is ruled out. And you take the second option, that is ECG. See, ECG is definitely very much useful in patients with the pulmonary embolism. And if the question is asked what is the most common ECG finding in pulmonary embolism patients, that will be sinus tachycardia. So sinus tachycardia, it is the most common ECG finding like what you will have in patients with the pulmonary embolism. Okay, but in this scenario is it required? Not required, right? So ECG is not the next step in her management because already the patient is giving you a history or we know the diagnosis that the individual is having pulmonary embolism. Then what is the use of doing ECG as a next step management in this patient is not required. Then insertion of IVC filter. See, first and foremost, very important point when you should insert the IVC filter is that when the individual is having recurrent pulmonary thromboembolism in spite of taking anticoagulation, then you need to put the patient on IVC filter. But here the question says that she is not currently on any medication. So keeping the IVC filter at this point will be very early without trying the patient on the long-term anticoagulation. And duplex of the lower limb veins and pelvic ultrasound. See, there are no risk factors for the development of deep vein thrombosis. So that is the reason why doing the duplex scan of the lower limb veins and pelvic ultrasound will not be of much useful, right? And definitely what will be the picture you will get by doing the lower limb scan? You will get the picture of if the individual is having any deep vein thrombosis, but there are no risk factors for the development of DVT. So doing the duplex scan is not an immediate next step in her management. So the immediate next step in her management will be thrombophilia scan. Now, you should know what are all the risk factors for the development of deep vein thrombosis. Now, I have just made a mnemonic for the risk factors for the development of deep vein thrombosis. So, the mnemonic is thrombosis. T stands for trauma or travel. H stands for hormonal replacement therapy, which is rich in estrogen. R stands for recreation drugs like the cocaine abuse. O stands for old age, more than 60 years. But if you take the age of our individual, she is only 41 years. So not even age is also the risk factors for the development of your DVT there. M stands for malignancy, which is a hypercoagulable state. B stands for the birth control pills, which are rich in estrogen. O stands for obesity or obstetrics. S stands for surgery or smoking. I stands for inherited thrombophilia or immobilization. So this inherited thrombophilia is the one like what I am suspecting in this particular patient. Then S stands for sickness. Sickness itself is again like we have a mnemonic for the sickness, that is conceptual. C stands for congestive heart failure. O is your orthopedic surgery. N is your nephrotic syndrome. C stands for central venous catheterization. E stands for essential thrombocythemia. P stands for paroxysmal nocturnal hemoglobinuria. T is your tamoxifen. U stands for ulcerative colitis and Crohn's disease. A stands for Apla syndrome. L stands for limited movement. So these are all the risk factors for the development of the deep vein thrombosis or pulmonary embolism. Out of which, if you take the conditions which will cause inherited thrombophilia, the conditions which will cause the inherited thrombophilia is factor V lead-in resistance, antithrombin 3 deficiency, protein C proteinase deficiency, prothrombin gene mutation, and as well as Apla syndrome. So these are the inherited disorders where you have defective inhibition of the coagulation factors resulting in the development of deep vein thrombosis and as well as pulmonary embolism. Right? Or the individual may directly land up in pulmonary embolism without having the deep vein thrombosis also. So going back to the question here. So in this question, what is the next best step in her management? You screen for the thrombophilia and accordingly you can give the treatment for the underlying cause, and as well as the next best step will be anticoagulation after checking the patient with the thrombophilia screen. So this is a very short video on the risk factors for the development of pulmonary embolism. So I hope you might have liked this particular short video. So please follow us on this daily dose for daily updates. Thank you very much.